Thank you so much to the Niagara Foundation for their great public service by providing these forums, and in particular to its executive director, Sharif Soydan, for his wonderful, wonderful work. Thank you so much for inviting us. Alcohol and drug abuse, including prescription drugs, is a major public health problem in the United States today. And we're fortunate that we have 3 experts that are going to talk about this serious public health problem in America. We have Kathleen Kane-Willis, who's the director of the Illinois Consortium on Drug Policy and Institute for Metropolitan Affairs at Roosevelt University. Kathy is going to lay down the groundwork and sort of give a very broad overview of the problem in the United States. Bill Heffernan is with us. He's the president of Employee Resource Systems. Bill works in the commercial arena, working with companies across the United States in helping their employees deal with this serious problem. And finally, we have Pam Rodriguez, who is president of Treatment Alternatives for Safe Communities. TASC, as it is known on, works very closely with the criminal justice system here in Illinois, and will be able to tell you the serious impact that this public health problem has on the criminal justice system. So to begin, we'll turn to Kathy.
Thanks so much, Michael. I'm going to play this a little bit differently than just doing the general trends in the general population. Just because I thought, hey, you know, statistics get boring, so I'm going to do this a little bit differently. So there are several ways to determine how prevalent substance use within a community is or in the general population. Most people turn to survey data to better understand drug prevalence among a particular population. For example, SAMHSA uses a national survey on drug use and health, which is given to individuals in their homes. Both Monitoring the Future and the Youth Risk Behavior Survey are given to students in school settings. While surveys do an excellent job at capturing a snapshot of information, they do miss hidden populations and, of course, have limitations. For example, those individuals who have very active substance use disorders, let's say addiction co-occurring with other mental illness, may not well be captured in surveys that measure use among the general population. They may be unhoused or living precariously and are not part of a household. In school-based surveys, hidden populations might include youth who have irregular attendance or who have dropped out of school. Therefore, there is no single reliable method of truly estimating the prevalence of substance use among all individuals, the general population. How do we deal with this issue? As a researcher, I like to use different sources of data to examine trends. For example, we might use a combination of hospital discharge data, emergency room data, some criminal justice data, public treatment admissions along with survey data, and we would love private treatment admissions too, if anybody could get that to us, to get a better idea of what's happening with a particular substance in a particular community. Multiple indicators give you multiple points of information from which to draw the bigger picture of substance use. Think of it as drawing a picture with a box of crayons at your disposal, the whole box, instead of 3 little crayon stumps. So, I mean, the surveys provide you with a good framework, but unless you're looking at multiple indicators, I don't think you have a full picture. Before I start talking about patterns of drug use in the general population, I would like you to consider the following points. There never has been, nor is there likely to be, a drug-free society. And when I mean drugs, I mean alcohol, prescription drugs, legal and illegal drugs. So when we're thinking about these trends, I want you to think a little bit about what we do with this information. We probably have some means to alter some drug use patterns to a certain degree, but perhaps not as much as we would like. Use patterns are long and complicated. They may change over the course of a generation. They may go up or down a little bit from one year to another. But looking at change in the use patterns from one single year to another is not likely to lead us anywhere terribly important. So it's better, in my opinion, to look at the general trend rather than to look at changes within a particular year. So with all of this said, what are some patterns that we are talking about in the general population? It's probably no surprise to anyone in this room that cigarette smoking continues to trend downward, showing a real difference over a generation. Less than 1 in 5 people in the U.S. smoke now compared to nearly 1 in 3 30 years ago. Well, that's a significant change. There are a good number of reasons for this decline. States have banned smoking in public establishments, including bars and restaurants. Public health measures detailing the health consequences of smoking have driven down use dramatically. Prices through increased taxes may have also lowered use. While smoking rates have decreased, particularly among older, college-educated individuals, among those with lower education levels, those who didn't graduate from high school, rates are very high and even higher among the unemployed. Nearly 1 in 2 unemployed people smoke. Considering the higher prices generated by taxes, you might think that the price of smoking would have increased so much that unemployed people wouldn't be able to afford cigarettes. However, one study in New York City found that among low-income smokers, 25% of household income was spent on cigarettes. Poor people with nicotine use disorders are impacted profoundly by the increased price of cigarettes. We need to think about new ways of providing help to these kinds of populations. This leads me to an interesting question. Why might people use illegal or illicit drugs? When people with health insurance and good access to care find themselves with a mental health disorder like depression or anxiety or post-traumatic stress disorder, they have a greater likelihood of going to a doctor for that problem than individuals who lack insurance or access to a doctor. Primary care doctors are now the greatest prescriber of psychotropic medications like antidepressants, far exceeding that of mental health professionals like psychiatrists. For individuals with uneven access to care or no access to care, how do they receive relief from their mental health problems? What remedies are most available to them? Illicit drugs and alcohol may be the most available drugs for individuals looking to self-medicate for their mental health disorders. And self-medication is not limited to the truly downtrodden in our society. Even among people with insurance or access to care, worries about stigma or personal disclosure of a problem to a doctor may prevent some people from seeking help. Turning to alcohol, cannabis, heroines, or a friend's medicine cabinet might very well be the more compelling choice. The easier choice, the simpler choice. I mentioned before that looking at year-to-year changes in drug use doesn't really lead us anywhere terribly interesting. But let's take a look at people that begin to use a substance in a given year. They may begin as a course of self-medication for their problems, or because it was offered by someone they respect, or just because curiosity got the better of them in that moment. The decision to begin using is part of an overall trend in substance use initiation that is worthy of closer examination. Initiation patterns do reveal something interesting. In the most recent survey year, about 2.4 million people tried marijuana for the first time. It's the most common illicit drug to try. Okay, so that's not terribly interesting. It's really what you'd kind of expect to see, right? But more than 2 million Americans tried illicit painkillers for the first time, and more than 1.2 million tried illicit tranquilizers for the first time. That means that more than 3.2 million people tried painkillers or tranquilizers for the first time, larger than the number of people who smoke pot for the first time. And when we are talking about prescription drugs, I'm not talking about using a drug with a prescription. These are illicit drugs most often obtained for free from someone close to you, a family member or friend, according to the research. What do these prescription drugs have in common? They are all depressants. Depressants suppress our central nervous system. They slow us down. The opposite of tea or caffeine or stimulants. They can make us euphoric, literally create good feelings, and can reduce pain. They also cause physical dependency and a significant withdrawal syndrome after continued use. This increase in prescription depressants initiations represents a significant change, a generational change, a profound change in use patterns. It has been some time coming. It has serious public health repercussions because of the risk of overdose and death and dependency. While depressant initiations have increased significantly, initiations to stimulants, illicit drugs like cocaine and methamphetamine have declined rapidly. So we have the opposite thing happening. Cocaine initiations decreased by 1/2, while methamphetamines have decreased by 2/3. At the same time, heroin use and opiate pill use increased. We might want to call this period, the age we live in now, the age of depressants. It is certainly not the age of stimulants. 15 million people have a substance use disorder where the drug in question is completely legal. Legal to buy, legal to possess, and legal to use. It also happens to be a depressant. This drug is alcohol. This number has remained relatively stable since 2002. In fact, the number of individuals who screened into substance use disorder for any substance, has remained stable at about 22 million. Further, more than 20 million of these individuals did not get the help that they needed in the past year. To me, this brings me back to the interesting question. How do we, as a society, make peace with the fact that people have substance use disorders, use substances problematically, and don't get the help they need? How do we deal with a society where people use drugs and will continue to use drugs? There is much to be scared of, fearful of, in the context of drugs. In fact, I would argue that so much of our world, the world we live in now, is based around fear. Fear of the new drug, fear of the old drugs returning, synthetic drugs, and drugs that have yet to be invented. Smart drugs, laced drugs, high-potency drugs, chemically enhanced drugs, every drug. And there are reasons for these fears. There will always be another scary, sinister drug lurking on the horizon. Drugs and substances have become our modern-day boogeymen. They have lives of their own. Even sometimes they seem to have wills of their own. They are evil. The drugs steal people's lives, sometimes their very souls. But the real issue isn't about what drugs we are using or what the drug du jour might be. It's learning to live with our fear around these issues, learning how to intervene, how to use limited resources to make a difference. In its essence, it's learning to have a better relationship with these substances. And I certainly don't mean that people should use substances, but demonizing them doesn't help either. It triggers the fear response. Fear overrides reason. Demonizing drug use doesn't get us where we need to be, which is to get folks into treatment. Demonizing drugs is one step away from demonizing the people who use drugs. Perhaps the reason why people who don't enter treatment or talk about drugs is because of the intense stigma surrounding drugs and drug use. Addict, junkie, alcoholic, drunk. All of these words and thoughts conspire to drive people away from the resources that they so desperately need. It's not the drug that causes substance use disorders. It is the relationship with the drug that causes substance use disorders. It is the individual's actions around the drug, legal or illegal. It's their actions, the way they act with the drug, how they use it, that causes substance misuse and addiction. And we have much to do to educate people about what substance use disorders really look like. This education needs to come quickly for our society to have a better relationship with substances and those who use them. Under healthcare reform, primary care doctors will need to understand what substance use disorders look like, how they are treated, and how to recognize them. The majority of doctors do not have that capacity now. And the science of treatment is far removed from the practice of treatment. Treatment needs to be delivered in a way that is based on what we know from research. And our drug education programs do not really explain the harms associated with drug use. They scare, and sometimes they do not educate, but simply recite platitudes to not do it. But I believe we can change this. I believe we can get individuals within society to better understand drugs. I think doctors can learn how to screen for substance use. I think that treatment providers want and will provide evidence-based treatment. I believe that our educators can simultaneously communicate accurate, realistic drug education while teaching that abstinence is the safest choice. I believe that we can make essential strides in lessening substance use disorders, but only if we learn to not make drugs the boogeyman. Only if we learn how not to stigmatize individuals with substance use disorders. If we can accept people who use drugs as people first and not as addicts or alcoholics or drunks or junkies or potheads. Not until we learn that nice people take drugs can we actually turn to the attendant harm associated with substance use and try to reduce it. Not until we learn to meet people where they are and use techniques to get them to move to more healthy behaviors. Not until we learn that much of drug taking comes from self-medication. Not until we learn that getting better from a substance use disorder takes time and patience. And then a little more time and patience. Not until we understand the episodic, relapsing nature of this disorder. Not until we learn to stop blaming people for the manifestation of this illness. We need to treat substance use disorders without judgment, without fear, but with mercy, just as we treat every other health condition. Each time that you begin to think of someone who uses drugs as a person first, instead of their addiction, the world changes a little. Each time you think of it an addiction as a disorder instead of a choice or a character flaw, the world changes a little more. Each time you think of substance use as a health problem and not a criminal justice problem, the world changes ever so slightly more. You have the power to make this happen. The paradigm needs to shift. The shift begins today. The shift begins with you.
Thank you so much. Well done and on time.
Well, as Mike said, I have worked in the substance abuse field since about 1984, starting out as a counselor in a treatment center and then as a director of a treatment center. When I first started working as a consultant in the industry, one of the things that was happening was right as drug testing and drug problems had become so enormous in our society. We had admirals in the United States Navy talking about how they couldn't get ships out of port because they didn't have enough sober sailors on the ships to maneuver them out of port. And when we started the whole notion of drug testing in the nuclear regulatory industry, nuclear power industry, and the transportation industry, it was a dramatic shift in our way of dealing with these issues. I can remember working with truck drivers who had been smoking marijuana for 15, 20 years, who smoked in the morning when they got up, smoked marijuana during the course of the day while they were driving their big rigs around the city of Chicago and across the country. That was just part of their lives. It was normal. And so I would submit to you that we have made a dramatic change over the last 20 years in terms of our country's dependence on and relationship with alcohol and drugs. There's much more to be done. There's much more that can be done. I'm going to go through some numbers with you and then some stories, if that's okay. Can I use the... As Kathy mentioned, SAMHSA and some other government agencies produce numbers, and what I want to focus on, my role is to focus on the workplace. I'm not here to judge anything. I'm not here to say something's good or bad. I'm here to talk about the relationship drugs and alcohol has in the workplace and some of the interventions that people have made with regard to that. So the important slide here is, as you look at this, you can see about 1/5, 20% or so of the young people who are entering the workforce are reporting the past month use of some illicit drug. So about 1/5. Once people reach the age of 26 or so, the number drops off dramatically to less or around 6% report the past month use of an illicit drug. So that period of time when people are entering the workforce, they're in college, they're beginning their careers, both academic and professional, in a trade, those are the times at which they're at the highest risk. Now, I've mentioned to several of you that I work with a lot of labor unions, and the labor unions have come to really appreciate the fact that when they bring someone into their trade, they're going to spend somewhere between $50,000 and $100,000. So if I'm an electrician in Chicago, they're going to spend 5 years training me to be an electrician. Once I enter the apprenticeship program, that trade union and its health and welfare fund owns me for all intents and purposes, in that I'm covered by them for every health condition I have.